No. You're going to die tomorrow.
Yeah. I'm gonna start. All right, so
Good morning, everybody, and welcome to one of our live multi-specialty institute endocrine department grand rounds. It is my pleasure to introduce our speaker today, Dr. Joaquin Lado. Dr. Lado earned his MD and PhD from the University of Santiago de Compostela in Spain. He has trained and worked in prestigious institutions across Spain, the UK, and the USA. In the board-certified internist and endocrinologist. Currently, Dr. Lado is a professor of internal medicine and the chief of the Division of Endocrinology, Diabetes and Metabolism at the University of California, Davis Health. He has extensive scientific interest and expertise in thyroid hormone and the biological action of thyroid hormone. And he's going to be presenting to us today the hypothyroidism caused by illness, a call to review the clinical practice. Dr. Lado, please.
Thank you, Sam. It's a real pleasure to be here today. This prestigious institution. Thank you for joining me. Now, the way that I'm going to present this talk is I'm going to introduce the concept, and then we're going to move to some pathophysiology. We're going to discuss some controversies, and then the last part. Please stay until the end. I know that sometimes we do a both because I'm going to present some exciting and new data that we think actually is going to change the field of that That's my last 10 minutes of the presentation is going to be about it. Now, when you do patient service, you always somebody came to you and said, "Look, I had this patient here in the hospital, in the ICU with this thyroid hormone. What should we do?" And that's what is was presented to us. You see here a very high TSH, low T4, low T3, and the first thing that they say is, "Oh, we should go to see the patient." We went to see the patient, and this is a young man, about 45 years old, who came to the hospital the night before with obstruction of the upper respiratory way. He was actually with his trigger, and he's going to be operating next. And they check the thyroid hormones. By the way, the thyroid is very nice. The thyroid, it's apparently not in pain. But he's going to have a massive operation. They're going to eliminate the larynx, and he's going to have a difficult feed for probably for weeks. He's going to lose weight. Should we treat this patient? Few fellows probably why not? Fine. Then I called from the ER for another patient who was admitted for headache. And I mean, you can imagine why.
That's not the same one.
No, this is another patient. Oh. And this patient was admitted for headache. You can see that the patient had a hypothalamic mass. It's probably a great fracture. And the pituitary is very nice. I mean, you can see here the pituitary is conserved. And those are the thyroid hormones. By the way, the patient had a central hypogonadism. So part of the process. You had a low T4, low T3, and the TSH is not low. You fellows may be thinking, well, is this primary or secondary? This is secondary, because the pituitary actually has not working, and you may say, well, why if the TSH is high, why the patient is not making thyroid hormone? Because these molecules, this TSH is have lower biological activity. That was shown in the 80s, but then because in that, when you had a central hypothalamic, the TSH and it's the activity. So then, yes, and this is a central hypothyroidism. Should we treat it with thyroid hormone? I think everybody will agree with give the thyroid hormone. But then let's see the third situation. So I'm calling and say, look, I had this patient in the ICU It's pretty sick, and he was admitted with, I had a low T3. But 1 week later, 10 days later, look, it's even worse. Now the T4 is low, the T3 is low, but even the TSH is in the lower side. Should we treat this patient? Let's go to see the patient. Right? Now, this is a man who is intubated, sedated. He had a tracheotomy. And he had an abdominal surgery because he had an abscess in the abdomen. And then here we go with this consultation. Are you going to treat this patient? Don't ask. I'm going to tell you. You are. And I cannot blame because this is what is called a non-thyroidism. I call it hypothyroidism associated with severe. And even when you prepare the endocrine or the internal medical board, you study these things, the medical quality physician. Even this booklet is telling you that the therapy with thyroid hormone didn't have any benefit in this patient. Well, look, I came yesterday from California to here and we traveled out of the United States. Why am I coming here? I'm feeling like Ossama here when the bull is hitting his leg. But why am I coming here? Just to tell you that we don't treat non-thyroidism, that this is worthless to do it. But let's see if I am able to change your mind here. Or at least if I will change your mind to give you more insight about how I see this.
How many times do you guys check the reverse T3 on these guys? That's what I do pretty regularly in a situation like this.
I don't do it, and I will tell you why. I mean, I don't do it because the rest of T3, you need to have a normal T4 to have the rest of T3.
That's true.
If T4 is low, the rest of T3 is going to be normal. Then why do bother?
It takes 2 weeks.
Put it in the pocket.
Yeah, and it's coming, it stays sometime. Now, I mean, we are in endocrinology division, but I should not go through this big bang, but probably should spend some time here. Now, when thyroid hormone reaches the cells, the thyroid hormones have probably two different types of action. One is called the genomic, and the other is called non-genomic action. Until the beginning of the 2000s, we didn't care much about the non-genomic actions. That's because all the field was focused on the genomic action of thyroid. But you know, after 2002, we start to learn more about this non-genomic action. For example, there is a binding site. We think that these are receptors for thyroid hormone in the plasma membrane. They are called integrin alpha-5 beta-3, who is actually a receptor mostly for T4 than for T3. And it regulates MAP kinase and can be involved in glucogenesis. A part of this effect, now, let's focus what's happening inside the cell. The thyroid hormones, they need to be transported. When I studied medicine in the 80s, we were told that the thyroid hormone just reach the cell. They just diffuse. Well, people who knew something about transporter say it's not possible because it's a polar model. It's a transporter, but the transporter was not identified. Was Theo Wiesel, who actually passed away already, and that was in Holland, who started to work in these transporters, and there is one transporter that is the monocarboxylate transport 8, who actually is very interesting because what I'm seeing here is a boy who had a profound delay in the development with an nearly blind. He had this kind of seizures when you touch him, he contracts, and he's not able to walk. And this is part of what is an X-linked mental retardation syndrome that is called Allan-Dudley-Hepburn. It's the oldest X-linked mental retardation syndrome that is caused by mutations in this transporter. We in Chicago and visiting in Holland, we at the same time we identified the first mutation in this transporter explaining this development. And that's actually after that, when you discover a protein which leads to a syndrome, everything explodes. And then the field of thyroid hormone transporter explodes after that. Then, yes, we now recognize that there is thyroid hormone transporters. And then when the thyroid hormone, the T4, come into the cell, it needs to be metabolized inside the cell under the action of the iodinase. Then T4 is converted into T3 by iodinase 1 and iodinase 2, or is converted to reverse T3 and the enzyme that is called iodinase 3. Then T3, which can be transported also or produced in the cell, had also in the cell two different actions. Could be non-genomic or genomic. The non-genomic actually is the PA3 kinase, and we're going to talk about this later on. Or they reach the nucleus where they bind to the thyroid hormone transporter. Those are transcription factors. They regulate gene transcription. And it stays some time to effect. Contrary to the plasma membrane, it's an immediate effect. The one in the nucleus stays some time. And there are two kinds of receptors, at least, thyroid hormone receptor 1 and thyroid hormone receptor beta. Alpha and beta. The alpha, we know at least two variants, alpha 1 and alpha 2, and it's important to differentiate because the alpha 2 is able to bind to the DNA but doesn't bind the hormone. Then it works as a dominant negative. Yeah, you have two thyroid hormone receptor alpha. One is able to bind the hormone, the other is not. And they bind to the DNA. They can compete one to the other. And the beta, we have beta 1, beta 2, in mice, there is also beta 3. There is slightly different in what they do, but they can bind the DNA and they can bind. Now, we all see patients they tell us after they remove the thyroid and you give the thyroid hormone, I don't feel the same. And she went, I mean, look, you've had enough thyroid hormone. And some of them are even hypothyroid. I am not the same. Then, depending how you are, which stage of your career you may say this patient is good. I mean, there is no limit. Or you may listen and think, well, maybe the patient is right, maybe we are not. And there is a whole lot of research now on the DNA, the action of hormones. But without to go there, remember, one thing is the thyroid hormone in the blood, and the other thing is the thyroid hormone in the tissue and the level of the receptors. What I am showing here is the expression of the thyroid hormone receptors, alpha 1, beta, alpha 1, and alpha 2, in different tissues. Those are from pigs under static shock. Those are control pigs, but it's part of static shock. And I don't have it here. But for example, look in the fetal log, it has the highest expression of the three receptors. Why is thyroid hormone receptor beta here? And look the difference with the cerebellum, hypothalamus, pituitary, the thyroid, lung, heart, liver, duodenum, colon, kidney, cortex, kidney, medulla, spleen, and adrenal. Look the huge difference, and look the relationship between the alpha 1 and the alpha 2, depending on the tissue. I tell you, those are receptors who are they compete one to the other. Besides that, look the level of thyroid hormones in the tissue. They don't correlate with the level of the receptor. Then you have, we in clinic go by the thyroid hormones in the blood. The patients are telling us something that we may be able to know. But we should know that every tissue has a different, when you compare the expression of the receptors between tissues, it's completely different. And the level of thyroid hormone, T4, is different, and the level of T3 is different. And when you do the index, look, you can actually quantify which one had more T3 regarding T4. Then, focus on the problem that we're talking today. What is this hypothyroidism associated with it? It's a very common condition observed during moderate to severe illness. Also in fasting, prolonged fasting, also can cause this. Biochemically is characterized by low T3. It may be associated with increasing the reverse of T3, and sometimes may be associated with increasing T4. The TSH is normal, and we call this inappropriate low, because by the feedback mechanism, when the T3 and the T4 is low, the TSH should be high. Sometimes it's even low, the TSH, and we will talk about that. And there are changes in the expression of genes involved in the action of thyroid hormones and the metabolism. But how common is this? How common is common? But how common is? Well, look, we did a study, we published in 2020, where we took at least 30, 60, 90, close to 100 patients, and we divided in controls. Controls are not completely healthy. Those are patients who come into the hospital do a knee surgery, minor surgery. And then we've been checking the thyroid function. We had 32, then we had 33 patients in the ICU in the first 48 hours that they admitted in the ICU. And then we had LTAC facilities. Those are patients that after a stance of sometimes in the hospital, they are transported to a LTAC facility where you don't see these patients anymore. They do not see. And then some of them actually have mechanical ventilation. They can be 10 years in mechanical ventilation. And then we've been studying the thyroid hormone levels. And look, I mean, in the ICU, these patients in the ICU is a variety of them. 80% of them they had low T3. But look, in the LTAC facility, up to 54 or 37% of them they had low T3. But when you check T4, at least 20, 25% of them they had also low T4. And here in this lower part of the picture, if you go here to the left inferior corner, this is low T4 and low T3. And there are the triangles and the side circles are the patients who are in low care facilities. These patients are not treated. Probably you will never see them. Occasionally they come to the hospital with pneumonia, then yes, it's common, it's very common, but we don't put any attention to it. Now, I told you that this is part of the, fasting can do it, but the patients who are in the hospital, many of them they have inflammatory response, and especially in septic shock, you can see huge level of not only cortisol, of interleukins. What we see is that a good correlation between the level of interleukins, this is the logarithm of interleukin 6, related with the levels of thyroid. Apparently, there is a good correlation between this pre-inflammatory response and the sense that in part the response is triggered by some kind of inflammatory mediators. Then why the TSH then doesn't increase? Because so far we see the problem, it's common, it's frequent, we don't treat it. But then I think that in psychology, our psychology, because the TSH is not high. No, because the TSH is not high, we do that. Because if the TSH, the TSH is 10 or 12, you will treat it. But because the TSH is 3, 4, you will treat it. Well, why is it not high, the TSH? Well, I thought about interleukins, I thought about this stress caused by inflammation. And all the studies, they show this is a hypothalamus, and this is in situ hybridization of the TRH. Okay, the TRH, remember, TRH stimulated TSH. And they took patients who died. This is a patient who died in the ICU with non-thyroid syndrome versus a control patient. Dots, these black dots is the TRH. And you can see that there is a big difference here between that. Yes, it seems that the TRH is blocked, and that will explain why the TSH is not increased. And why is that? Well, we know that interleukins, I showed you that there is a good correlation, and there are studies in mice that when you treat the mice with interleukin 1, there is a decrease. This is the control, this is the interleukin 1, and this is the hypothalamus, the TRH. The TRH decrease as well as the TSH. The TSH also decreased. Then these interleukins, potentially, they block the secretion of the production of TRH and the secretion of TSH. However, the pituitary responds well. There are studies in humans. If you take these patients, you take the patient, and you give them TRH, TRH during 40 hours, you can see here the TSH response. Then, whatever is happening in the pituitary response if there is TSH. But you need thyroid hormone to block the TSH. Why I say that? And just back, we were thinking that the TRH doesn't increase because interleukin is blocking. Well, but to see this effect, you need thyroid hormone. Now, I was working in Texas. It's probably my favorite state. But the healthcare is broken. And in West Texas, many people doesn't have insurance. And in day 15, they stop the medication. and they don't take it because they cannot pay. And then occasionally we see patients in the hospital, like this man. Okay, I'm sorry. Probably you cannot hear because sorry. This is a patient that you can see is very high. This is a 59-year-old man with severe primary autoimmune hypothyroidism. He had a colon perforation. He had a myocardial infarct. He had a ejection fraction of 14. He's in heart failure. He had a GI bleeding, ended in the ICU a long time under sedation and intubation. But I guess he's sick, no? Sick. It's pretty sick. Look at TSH. It's very high. T4 is low. T3 is low. As soon as I start to give him IV T4, look at TSH. Beautiful response. How fast? How fast? Actually, very fast. He comes down. 4 to 4. Yeah, and this is 175 of T4, 100. This is from today here, starting already coming down.
This is sort of 2 weeks pretty much.
Yeah, at the end, because eventually he passed out. Now, I got interested. I said, well, that's interesting. Then I start to collect cases of these people who don't take the medication but doesn't know. And there are several cases of very sick patients. I mean, look at this with the TSH 500. Very sick patients, different conditions. That when you give T4 is when the TSH. Then, to have a suppression in the TSH, you need to have thyroid hormone. And that could be explained by this finding, where here this is MASH, and this is the hypothalamus, and this is the iodinase 2 expression. Remember, the iodinase 2 is the enzyme who convert T4 into T3 in the tissue. And here is the control mice, and he's a mice treated with the LPS, lipopolysaccharide. It's a way to trigger a very significant inflammatory response. White spots is the iodinase. Look what's happening after you treat the animals. So there is a huge induction of D210. We think that is what's happening is the inflammation in the brain triggered an increase in the activity expression of T2, who is able to keep the level. The little T4 that is going to be there is converted into T3 and then blocking the increase in the level. And that would be the explanation in this case. It's 2 different stories. Then, frequent problem. We know that why the TSH, or we believe that why the TSH is not increased, is keeping within the normal range. And now, what is causing the low T3 then at the beginning? Because when the disease is low, then T4 is also low. What is causing this? Well, this is an example. No, patients on the ICU with sepsis and no sepsis, all of them they have low T3. This is the control group. This is the patient with that's part of that study that I showed you. Now again, remember that the thyroid produces T4, but only produce 30% of the T3 in the circulation. And where is coming the rest of the T3? It's coming from liver is an endocrine organ, and the kidney is an endocrine organ. They produce, at least it's a thyroid, it's a organ which is able to produce thyroid. And then both liver and kidney, they produce about 70% of the T3 circulating under the action of the iodinase. If you don't believe it, look, this is for humans. This is immunohistochemistry of the iodinase 1 in the liver, all this brown.
One?
The iodinase 1,
Okay.
immunohistochemistry in the liver and in the kidney. This is the glomeruli. You can see the two.
Yeah.
Compared with the thyroid. The iodinase 1 in the liver and in the kidney is much expression is much higher than in the thyroid. That's the base for why the liver is an endocrine organ. And by the way, I mean, if you want to do the trial, take patients with any stage renal disease. You measure T4, nearly always is not. Measure T3. You will be all of them are hypothyroid, like people with failure, because those are endocrine organs. Then what we did is we took humans in the ICU, set the shock, we're doing biopsies, what we can do biopsies, the skeletal muscle and in the fat. And then we were measuring the activity, not the expression of the urinase 1, the urinase 2, the urinase 3. Then the muscle doesn't have the urinase 1 activity. It had very little activity. But look what happened in the urinase 3 in septic shock. There is a massive increase in the activity of the urinase 3 in the muscle. The urinase 3 degrades T4 into reversal of T3. Okay, then, yes, during the septic shock, there is a reduction, at least in the skeletal mass of the urinase 3. And we didn't see much in the adipose tissue. We saw attendance. By the way, nobody thought that there was the urinase 1 in the adipose tissue. There is activity. I don't know if this may play a role in obesity. It will be very interesting to see what's happening with this side. Because, do you know anything who stimulate the weight loss more power with blood thyroid? It's nothing. For some people, it's a joke. Blood thyroid. If you had experience, it's not unusual to see a person who lost 60 pounds under a very severe hypothyroidism. If they had acid. I had a patient in Texas with 100 pounds. I didn't recognize the patient. Now, again, we didn't see difference. Then we create a model of pigs where we induce a septic shock line syndrome, giving FPS. We give FPS, and we study the pigs for 48 hours. And then we can collect tissues for every part of the pig. And then this is the urinase activity in the liver, cortex of the kidney, and cortex of the medulla. We saw a significant difference in the kidney cortex, that there is a decrease in the activity of the one. Okay. Here we are, T4 is converted to the reversal T3 going to T4. Okay. Oh, excuse me, T3. And this is under the urinase 1. The urinase 1 is go up, and there is less T3. The urinase 3 is increased, there is more reversal T3. We didn't see the liver, but I think it's probably statistical because it's.
Why you guys didn't look at the urinase 2?
Yeah, we see. Okay. The urinase 2, I'm going to show that. But I can tell you, we didn't see difference in the urinase. But the urinase 2 is very tricky. It's very tricky to measure, but we didn't see. Now, the urinase 1, yes, there is a decrease in the activity of the urinase 1 in the kidney cortex. We think that also in the liver, and the gene expression is much lower. This is the gene expression. Then the gene expression decreases, and the activity also decreases. And then we measure the urinase 3 in every tissue of the animals, and we saw an induction in the hypothalamus and in the liver. Look in the liver. Then the liver produces less T3 because the urinase 1 decreased and because the urinase 3 increased. And that's the liver. And then we did the urinase 2. Yes. Then, again, frequent problem, TSA does not increase. We think that we understand the mechanism. The decrease in the production of T3, we also think that we understand the mechanism. But other than to have a low T3, sometimes low T4 in the blood, are the organs hypothyroid? Defining hypothyroidism as a decrease of the level of thyroid. Then, yes, we collect samples and we measure thyroid hormones in every tissue. Then, here in this graphic is the serum level. This is pigs under septic shock, where we measure T3, free T4, reversal T3, cortisol. And this is the control animal at the beginning and at the end of the experiment. And this is the control septic shock at the beginning and the end. You can see that there is a decrease in 40 hours. Actually, it's very fast. The level of T4 and the level of T3. The level of T3, there is no statistical significant difference because T4 is low.
Yeah.
And then, to have, there is a tendency to increase, but you need to have T4. If T4 is low, you cannot have it. And the cortisol, there is a huge response, variety of responses. Well, now look in the tissue, look the heart. I want to focus on the heart. There is a decrease in T4, and there is a decrease in T3. There is a decrease in the liver, there is a decrease in the kidney cortex, there is a decrease in the skeletal muscle. In the brain, T4 is low, but T3 no. This was very interesting because I thought that it was a mistake. The T3. Yeah. And I called Maria Jesús Obregón in Spain, who's my collaborator. I told Maria Jesús, I think that you're doing a mistake. I never should say that. She thought I never made mistakes. Did you know Maria Jesús? Huge woman, very good. And then I told her, she told you figure out. I said, okay, well now, remember what they told about the induction of the urinase 2 over there in this animal study. Now, I think actually that the level of T4, the brain has something to do. Is taking T4 from the transporting to the brain. The brain always needs 1 Celsius. And it's working also 1 Celsius above the body, which means the temperature. And remember, thyroid hormones keep the temperature. And I don't know if this has something to see with the role of function as a mechanism to keep the immunity. I don't know about that. Something that we probably could be entertaining. Then, okay, now, TSH do not increase. There is low T4, there is low T3, there is hypothyroidism. Well, and what? Because you may think, well, I'm going to need now thyroid, but then it works. How is the receptor? How is the receptor? Because you may be facing a situation where you need thyroid hormone, but there's no receptor because the receptor is blocked. And we also measure the expression of the receptor. And this is human studies, this is skeletal muscle, this is root Q tissue, and this is thyroid hormone receptors here. Those are other molecules. You can see here in the skeletal muscles there is a significant decrease in TR beta, there is no decrease in TR alpha, and in the fat there is decrease in bones. Those are 2 tissues. Then what about in the other tissues? And we took tissues from pigs, from the frontal lobe, cerebellum, hypothalamus, pituitary, thyroid, heart, liver, kidney, spleen, adrenal, skeletal muscle, and we did a panel of different molecules. And look, not TR beta is the one who is more affected, is one of the receptors. TR beta is starting significant difference means decrease in the expression, the stars. But look, the alpha is not that much. It's not that much. I am very interested in the heart, in the alpha, because the alpha is the one who controls most of the action of the thyroid hormone in the heart that I want to go and show you. And yes, I mean, there is a decrease in the expression of thyroid hormone receptors that is changed from tissue to tissue. Now, there is something that we didn't do it. We should probably do it. That is the occupancy of the receptor. Because you may have a low receptor, but let's say that this is the level of the receptor and the occupancy is 20%. Now the receptor decreases, but you increase the occupancy 20%. And this is not enough. I don't know anybody with the occupancy. It's something that we are still missing. Okay, then TSH do not increase, thyroid hormone decrease, there is hypothyroidism, there is less expression of thyroid hormone receptors, beta and alpha, but depending on the tissue. Then, non-thyroid syndrome is a condition where there is an impairment in the hypothalamic production of TRH. There is low T3 because there is a decreased activity in urinase 1. There is consumptive hypothyroidism because there is an increase in urinase 3. And there are tissue-specific decrease in thyroid hormone sensitivity because there is a decrease in thyroid hormone receptor. We're also checking this part. Now, for those of my age, you probably knew Dr. Bartowski.
Yeah.
I never met Dr. Bartowski. Dr. De Groot, I had the privilege to be trained. Was an amazing man. He's not with us. He's the one who wrote the Harvard Bible, the root of endocrinology, and also the site manager who is free. The editorial didn't want to pay nearly anything. He said, well, now I'm going to write by myself a book. He convinced Up, who was paying, he put the book. The same, site managed by Clinic EMI. That's what Dr. did. And there was a big controversy in the 90s, 2000 about to treat or not to treat. And it was more theoretical elaboration about that. Now, Dr. Bartowski wrote, will advise withholding thyroid hormone therapy in the critical care setting. That's what Dr. Bartowski was actually, he convinced everybody. Dr. De Groot was the opposite. He used to go, if you train with him, he was giving thyroid hormone therapy. The patient improved, he was telling you, see, we say the patient died, he was doing nothing. But that's how things went. Now, in 2014, the American Thyroid Association published this guideline for treating hypothyroidism. And regarding T4 and regarding T3, they basically do not recommend. They do not recommend. It's very interesting to see who is these people. Because I don't know anybody except chronic working in this field. I mean, they are very respectable people. They are Tony Young. I mean, Catholic Jonkers, popular. They never work in this, but they are right. Now, what they say? They say that the data of these clinical trials are limited. The studies are involve a small number of patients, and they suffer an heterogeneous life-threatening illness. Okay, then we have very few studies with few patients with a picture of disease there, but we recommend not treating. Then they say that there is no benefit in the major clinical endpoints because the endpoint is survival. Well, I mean, if you're taking an heterogeneous life-threatening illness, meaning if I cross the road and it's hit me and broke me for 20 times, 20 places, what happens? Thyroid is going to save my life. I don't know. Maybe we have to select the cases. Then this is an important call here that they say that there is one study that T3, high dose of T3, achieved T4 increased mortality. This is in kidney failure patients. And this study showed that when you give 4 doses of 150 micrograms of T4 to patients on acute kidney failure, there is a huge difference in mortality 1 month later. 1 month later. However, other studies show that lower doses of T3 could be beneficial. And then this is the one that I highlight. In the current practice, I don't know which practice. Most clinicians interpret the data as more favorable to thyroid hormone replacement. Okay, where is the statistic? I mean, you are letting people to treat it, of course. You are favoring. No.
You know, when you go to the American Thyroid Association, they do pass those like surveys, like, you know, what would you do with this there? So, you know, they maybe, but they should.
Yeah, but if I tell you don't treat, and then I find the statistics, what do you think? You're going to say, well, you know. Now, this is the study. I'm not going to go into there. I mean, yes, it's the issue of the mortality. It's very interesting to see that the control group had a mortality that is about 30% and the treatment with 43%. Everybody knows that an acute kidney failure, especially on chronic kidney failure, the statistics show that the mortality is about 40%. And they have actually this mortality. They cannot explain this difference. There is something weird about that, and it's the only study that I know. But then, yes, by today, this is the view. We don't treat it. Now, why I'm jumping here? Septic shock cardiomyopathy. Well, the cardiomyopathy or septic shock is a reversible condition that is may last an average of 7-10 days. And it's caused, increase the chances of death. And it's caused by pro-inflammatory cytokines, especially interleukin-1 and TNF. It's caused by a systolic and diastolic dysfunction. And these patients sometimes they go to the hospital, they are admitted in the septic shock, the ICU, and the heart is not pumping. And there is a decrease in the ejection fraction, and there is also a problem in the transmission. Septic shock causes myocardial hypothyroidism. I already showed you that. Thyroid hormones have a very powerful effect in the heart. This is a myocardial fiber from a pig, where you can see here the nucleus. All of these are mitochondria. Look how many mitochondria. Perinuclear mitochondria, subsarcolemmic mitochondria, and interfibrillaire mitochondria. Those are the fibers of the heart. And thyroid hormone regulate the energy, this balance the energy, fat transportation, glucose, and fatty acid metabolism. And also what is called the easy coupling, the excitation contraction of the heart through the beta-adrenergic receptor. And all these dots is where they are thyroid hormones. Very diffuse. Hypothyroidism is caused by myocardial dysfunction. We just showed that. We just sent this communication together. We took 100 patients between Davis, Kansas City, and Spain with mixed coma or very severe hypothyroidism. And how do we find very severe hypothyroidism? Well, the TSH is they may high before, and they are. We cannot say that they are mixed coma, but they are in a pretty bad shape. This is the TSH level of the group, and this is the 24 level of the group. And then we measure, this is a perspective study. But you know, the imaging surgery, the cardiologist can take this, run a Toltec software to evaluate the strain, myocardial strain of the heart. It's called global left ventricle global longitudinal strain, right ventricle global longitudinal strain, and the left ejection ventricle. Left ventricle ejection fraction. 26% of the patient had increase in the ejection fraction if we consider 50%. And another good percentage is borderline 50%. We don't know what happened when they are treated this way. But look, the left ventricle global longitudinal strain is a marker of myocardial dysfunction, 73% of patients. Then yes, I believe that myocardial dysfunction because not only a chronotropic effect, the hypothyroidism also had an inotropic effect. We believe and we have that. Now, the excitation and coupling of the heart is regulated by the beta-adrenergic receptor. The adrenaline, or noradrenaline, or epinephrine, bind to the beta-adrenergic receptor. That is a G protein coupling receptor. Stimulate and release cyclase, increase cyclin P, stimulate PKA, and PKA phosphorylate proteins who are involved in the calcium spark and contraction. We can now put reporters that they are called Fred reporters, hook it in different parts of the cell. These reporters can be activated and then they reflect the cyclin P or PKA of Fred reporting. Then this, for example, we can hook it in the plasma membrane close to the adrenaline circulation. And then when we stimulate the cell with isoproterenol, that is a beta-1, beta-2 agonist, we can check the activity, for example, PKA. Okay. You give isoproterenol, and immediately in seconds, you see an activity. Monitoring this Fred. I told you that septic shock cardiomyopathy is caused in part by pro-inflammatory cytokines, one of those is TNF-alpha. Actually, it's very interesting because the guy who discovered this is working here. Naga Prasad is a cardiologist over here, and he showed that TNF desensibilized, cause desensibilization of the beta-adrenergic receptor in this way, bind to PA3 kinase gamma, recruit GAG2, phosphorylate the receptor, and bind to arrest. And this is the way that causes desensibilization of the beta-adrenergic receptor. That is a big deal because these patients do not respond to catecholamines because there is beta-adrenergic desensibilization. And here is what is coming, the very interesting thing. We start to work in a cell line, it's an embryonic rat cell, cardiac cell line, where we culture the cells, and then we transfer the cells with different reporters that can be bind to the plasma membrane, to the ryanodine receptor, to the SERCA receptor, to monitor the activity, and even one that is measured cyclin P in the cytoplasm. Control group, you stimulate with isoproterenol, that is the green, and you see the response. You give TNF with isoproterenol, block the response that we expect. And block the response with the plasma membrane, this is plasma membrane, the production of cyclin P, the production of the activation of SERCA, and the reaction.
I can't see it up there. You're sure.
Okay, sorry. Okay, this is the plasma membrane response, the PKA activation, cyclin P, and this is the SERCA activation and the ryanodine receptor activation. When we give TNF with isoproterenol, we block the response as we expect. And this is the surprise. When we give T3, we incubate the cells with 60 minutes with T3. We prevent. We were actually slightly confused and thinking, because this is a very fast effect. Then we took cardiomyocytes, we isolate cardiomyocytes, and we repeat the experiment. There's not in a cell line, and we see very similar results. This is in the plasma membrane. We are monitoring PKA activation in the plasma membrane. And remember, PK activation is crucial for the station copy. Then we stimulate the cell with isoproteinol. We add TNF, and again, T3 prevent the issue. Now then, we actually can do even, we can do more things. We actually can take the cells and we can measure the contraction of the cells here under different conditions. And this is the basal cells, the basal contraction. When we give isoproteinol, we expect that the contraction increase because that's what isoproteinol do. TNF block it, do T3. We prevent it. And when we measure calcium, we had an imaging system to measure. We had the basal, the isoproteinol stimulated calcium going in, blocked by TNF, is prevented by this. Then we actually measure the phospholamban. What's happening is you need to phosphorylate phospholamban to inhibit. When you phosphorylate phospholamban to inhibit and allow then the calcium to come back to the sarcoplasmic reticulum, okay, to end the contraction. Then, when you give isoproteinol, that's what isoproteinol do, increase the phosphorylation of phospholamban. When you give TNF, you block. When you give T3, you rescue the block. Then it's not only an effect that we're seeing in the plasma membrane, we're seeing also at the sarcoplasmic reticulum, we're seeing at the phospholamban. Then the effect of TNF is dose dependent, and we are able to block it with T3, but we are not able to block it with T4. And this is a T3 effect, it's not a T4 effect. And it's required a receptor, because this here is the T3 rescuing the effect of TNF. We block the receptor with this molecule. We don't know if it's alpha or beta. This is a non-specific blocker receptor. When we block, we are not able to rescue.
Which receptor you block?
The alpha and beta.
Oh, so you beta is not
I
energy.
cannot tell you. But I can tell you now, it's TR alpha. Because
No, I was wondering if it's like the energy receptor or
no, the thyrohormone receptor. Yes. This molecule block the thyrohormone receptor, alpha and beta.
Okay.
And then we rescue. I mean, we cannot rescue the T3 effect. Then there is a requirement of thyrohormone receptor. I can tell you it's the alpha. We already have that source. And CB1 cells, they don't have a receptor. Same, you cannot rescue with T3 the effect, and we didn't see. Then T3 prevent the beta desensibilization of the beta adenylated receptor caused by TNF alpha through a TR alpha 1 mechanism that we think that is non-genomic. This is our hypothesis, is that T3 bind to the thyrohormone receptor alpha, and based on the studies of Naga Prasad, we think that we block PK83 kinase and GERD and the desensitization. Okay. Now we had GERD knockout mice and we had GERD knocking mice. Then, if you have a knockout mice and GERD is part of the problem, the knockout mice should not show the phenotype of TNF, and that's what's happening here. This is TNF, and those are isoproteinol, and this is isoproteinol with this over here is the GERD match. It doesn't matter if you give TNF or not. And the knocking is the same. Apparently he's right. GERD is involved in the beta desensibilization caused by TNF. And then PI3 kinase, he said that it's the gamma. We don't have the results because when we blocked PI3 kinase, it doesn't matter if it's alpha or gamma, we rescue the effect. Apparently, gamma has both PI3 kinase are involved here. We are now doing experiments. We already sent one of these things to the meeting that's going to happen in San Francisco to present for the first time. And actually, you're the first group. The first group you see this. And And this is all the people who are working with me. Santiago, this is my first group in Santiago de Compostela. I'm very proud of these people. He's now the president of the European Society of Lipodystrophy, who was, I think, he's a real star in the NIH. He has 2 PhD, and he's also working in the one is in bioinformatics, the other is in biochemistry. He owns 3 companies, pharmaceutical companies in Spain. Very smart people that they ever work. And Theo Vice, who already passed out, is one of the 5 members of the sport, was thyroid hormone transporter. And Maria Jesus Obregón is our against the one person. People that they worked in Texas, amazing team. And now Professor Jan Kevin Xian, who is a phenomenon, came from Kubilka Laboratory, that is another prize, better than other receptors. Kubilka and his staff, and he came from his lab. He's a full professor, very well funded for the NIH. And this is the studies that I'm showing in that work there. And that's it.
So this whole thing suggests that maybe a little bit of the treatment may be useful.
Well, months ago I contacted Ossama because we were trying to put a multi-disciplinary clinical trial in the effect of thyroid transformation. I've been negotiating with the NIH for 6 months, and we don't go anywhere because they tell me that they want more. They think it's a joke. That if you give thyroid, you're going to kill someone. This is basically, and I'm showing that from my clinical practice. I'm treating patients with T3 and even published. There's nothing happened. Well, we want that. Now, what we did is we just submit another one in pigs, creating the model and giving T3, studying this kind of things. Then the human study is going to be delayed. Although we had a protocol approved today, we had a protocol of doing it.
You have this septic pigs.
Yeah.
That would be probably.
Yeah, but that would be now requested from the NIH a funding to do the studies on pigs. Septic shock, giving T3. Actually, it's a pretty complex.
But it's also not easily transferable to humans because the ratio before T3 and pigs is different.
Well, but they develop, yeah, it's true, but they develop the thing, and the heart, the big heart is not exactly, the only problem that we're going to face is this animal, they died. Who say that the pigs are the ideal animals to study cardiovascular disease because they didn't work there. Because the animals, they died like 50% of the answers are going to go very fast, but hopefully.
In your practice, this is great. At UC Davis, is the only one treating with thyroid hormone in this situation, or?
Well, at UC Davis, I don't treat. I do 12 weeks of inpatient service. If they call me, they will have T3.
Yeah.
Now, the problem is for the T3, very expensive.
Yeah.
It's 5 micrograms is $300.
Yes.
The hospital don't want to give it. If I do it, they will give it. There was no T3 for a while in the market. For a year, the company did the manufacture. Now we have it. But they don't want to. They give it to the oral. And we give it. The people who is working with me, when I keep using this, they were not even mentioning T3. It was a big problem to convince people in the division. And now, for example, for the clinical study, one of the problems that we are facing is that the lab do not report T3 every day. That is amazing to me. Now they are doing every 2 days, but if the patient is during the weekend, you are in a trouble to run the test. Then yes, we are doing it. We want to do it. In Texas Tech, that was the standard care. If the patient did, of course.
Now, in the critically ill, do you when you're testing for T3, do you prefer the free T3 or the
I do free T3. I am aware about this or this literature about the acids.
That's all these proteins can be up and down.
Yes, but I think that this was more free T3.
So it is a good idea to rethink critical illness. Like the consensus is we don't treat the hypothyroidism from critical illness, but there are certain critical illnesses, such as the septic shock associated cardiomyopathy, that we think there is some benefit to.
Well, I cannot tell you there is benefit because we don't have studies. Yeah, of course, I made this and carried here is, for example, don't forget that the vasodilatory effect of thyroid in septic shock would be a problem.
Yeah.
Because what I'm showing you is the resource in the heart. I don't have resource in the artery. We are starting studies in the artery because that could be a completely different thing.
Yeah.
And I always have it in the back of my mind. We're working with people who have hypertension. Although we think that we can reverse in the heart with desensitization, what happened in the heart? I mean, what happened in the arteries? We don't know about that. And I cannot say if it's a benefit. For me, it's more than enough, other than to keep me busy, to give answers. But I don't accept as endocrinologist. You go to the hospital immediately, you have steroids. Yeah, steroids is that God came to the hand. Why are you giving steroids? Why? And then if you give thyroid hormone, because it is metabolism, and you ask what does it mean is metabolism, elaborate a little bit. Well, yeah, and when you ask 3 times what this means, I doubt that you find many people who is able to give you an answer about metabolism. But people don't understand metabolism. And we're physicians. If you talk about lipids, you talk about glucose, you talk about then steroids, they are not catabolic. I mean, I think I'm more of the thyroid hormone. I cannot argue the thyroid hormone will increase the temperature. But they are anabolic. What is it? They are anabolic, depending. Those are the diseases that it goes in the brain. And
so before I leave, I guess my patients on the way is one more thing that obesity field now are trying to actually deliver thyroid hormone only to certain organs.
Yes.
By attaching them to another organ who has receptor only in certain tissue. So that is probably another part.
Yes.
So can you maybe in this kind of situation, critical ill people deliver the effect only on certain tissues.
Agonist only working. Right. And even for fatty liver.
Right.
People for fatty.
Yeah. I got to somebody's waiting.
All right. Well, if there's I don't see any questions on the chat. Any questions from our audience here, our fellows?
One question is, have you used T3 in other settings other than septic shock, just for non-thyroidal illness, or?
Well, not in clinical trial, in my practice. When I was the only endocrinologist for 8 years in West Texas, in an academic institution of 500 beds. Meaning, I was living in the hospital. That had disadvantage, but it had a lot of advantage. People know you because you are there all day long. Then the ICU, I was part of the ICU. And then every time that they had a polytrauma, or I had somebody who, that the thyroid hormones were low and they did not recover for reasonable period of time, and the patient had to be there 7 days, 10 days. I was treating with T3. I never had a problem. IV or oral. Yeah, and a different variety of polytraumas, neurosurgery, good patients. I don't have a number to talk about, but it was many patients.
And when do you consider stopping it? Is it once the numbers improve, or like?
No, it's not when the numbers improve, depending on the situation. If you treat it and then you reach a level over there, the patient improves, I can stop it. They not. And now patients are asking you to get T3 also.
But isolated 3 only? Would you give?
No, T4. T4. For example, it's very interesting. The TSA response is directly related to T4, not T3. It's not to T3. It's directly to T4. Still don't understand much that. There's no correlation with T3, but there is a big correlation with T4.
So if you're giving to somebody in the ICU thyroid hormone, how do you gauge your therapy plan or the effectiveness of
yes.
therapy and how often you check?
Yeah, I normally, well, in my hospital, every 2 days, you cannot do it less than that. You know, maybe 2, 4 days. And if I give T3 IV is 3 times a day, starting with 10 micrograms, and then going through that. 2 days later, check the level of T3.
And your target is to normalize the level of 3T3
Well,
guided by.
just to give that. I don't know if it's normalized, because sometimes it's very difficult.
Okay.
But just to give that from need a combination. Now, I had to tell, I didn't show you that. But there is a G protein called receptor 44. We had it. Now we don't know where it is. Well, we know that it's in the plasma of the brain. We don't know what it is the receptor. Hopefully, we can isolate it sooner than later. There is a G protein receptor that probably is related to the transport of electrolytes in the heart, sodium, potassium, and calcium. How thyroid hormone cause tachycardia? How? I don't have it. I know that it's called tachycardia, and I know that it's a beta blocker. But how? I've been looking into this for a while. I don't understand.
But doesn't it enhance the action of norepinephrine,
Which one?
the thyroid
No.
hormones?
No, we know that hypothyroidism, the expression of the beta receptor in the plasma membrane is not extremely low. We think that there is an activation of the cyclin P pathway, and we give it a blocker to stop it. But nobody showed how thyroid hormones cause tachycardia. We don't know. I mean, I would like to say somebody showed me a paper that this is how it's caused tachycardia, but I don't know.
Yeah, we always learn that it potentiates the effect of.
Yes, potentiate, yes.
Yeah.
And we stop it with a block.
Yeah.
Again, potentiate.
How
And
the mechanism.
what I know is that there is a G protein receptor. This is working. In the 80s, there was already studies from the group of Inger showing that thyroid hormone increase cycling. Nobody gave a damn. There was about 10 studies and then some effect of, but it was magnetic. Came with the thyroid hormone receptor, everybody moved to the thyroid hormone receptor, because then you had a protein and then you had a syndrome. Everybody forgot about that. I showed the data to Sam the other day. He knew very well. Because yes, I remember that, and I remember how that was forgetting. I told Sam, there is a T protein receptor. There is a T protein receptor.
So we still have quite a bit of things to learn about the thyroid hormone, biological action and signaling. Thank you, Dr. Lado. That was very